I was interested. I carried it through with a thread throughout my graduate years. So my master's thesis was a project that surveyed incoming college freshmen on their eating disordered attitudes and behaviors and drinking behaviors and campus participation in Greek life and other activities. And I surveyed them again 2 more times in their sophomore and their junior years, just to really understand what is the longitudinal course of eating disordered attitudes and behaviors in those first several years of college. Because it's always talked about, right, that college really influences eating disordered behaviors, and maybe certain groups on campus might be more susceptible than others. And so I was really fortunate that I was able to see that through and defend that in my 4th year of graduate school, and then went on internship afterwards. And what I found was actually pretty interesting. So at Miami University, Greek life was actually quite popular. So it was a pretty even split in my participants between those who were in Greek life and those who were not. And it really did show that women who were not in Greek life, their eating disordered attitudes and behaviors stayed kind of constant over those first 3 years, and those in Greek life, they actually increased. So, that was one interesting finding. And then the other part that was interesting is we monitored weight gain over those 3 years, really to see, check out the freshman 15 idea. And it was more like of the freshman 3 to 5 pound weight gain. So we surveyed people at the beginning of freshman year and the beginning of sophomore year. So by the time people came back for their sophomore year, the weight gain was somewhere between 3 and 5 pounds for most people. So those were kind of the 2 main findings that I took away from my dissertation. And I would say at that point, I was really just wondering, what do I want to do? I always thought I wanted to hang out my shingle somewhere, practice clinical psychology, just see patients all day, basically. And the year of internship after graduate school really is focused on clinical work, right? It's making sure that you're competent to go out and practice ethically and, and safely, and really, help your clients. And so there isn't a big research component in most clinical internships. And I realized I really just missed the research. And I thought, you know what, I really did enjoy doing my thesis and my dissertation. And I don't think I want to give research up. And so at that point, you start interviewing for postdoctoral fellowships pretty early on. And I realized, I think I want to keep doing research. And so I interviewed at Yale with Kelly Burnell, who was and remains, he's at Duke now, but big in the world of obesity research and disordered eating. He does now a lot of stuff with food policy, really interesting guy. I interviewed there. I didn't quite get that one, but we did have a good interview, and he referred me down here to Penn to his former mentor, Dr. Mickey Stunkard, and I ended up getting the postdoc with him. This was in 2000. So many of you maybe weren't even born. So I came as a postdoc to Penn in 2000 to work on something I had never even heard of before, called night eating syndrome. And Dr. Stunkard had first described night eating syndrome back in 1955. And when he was doing his initial phone interview with me, he said, "So have you ever heard of night eating syndrome?" And I had done my work, right? I had read his publications, gotten ready for the interview. He had done, just so many different things, but I didn't read anything about night eating because that was back in his really early days. And here he was getting funding from the National Institutes of Health. I didn't even realize he was almost 79 when I talked to him and ended up starting working with him. But I had to say, you know what? No, I don't know about it. But he was such an enthusiastic, such a unique guy. He was more than happy to tell me about it, that it was this delayed pattern of eating, such that people don't start eating till later in the day. They end up eating more and more as the night goes on. And then many of them also get up in the middle of the night and feel compelled to eat. And so I said, sure, that sounds pretty interesting. There wasn't a lot known about it at the time. And I jumped at it. And I'm originally from Wilmington, Delaware, and that's actually where I live now. I never thought I'd end up back here, but here I am. So I thought that's great. I could be close to family. And yeah, and I've been here ever since. And we spent many years really characterizing night eating syndrome. We developed a cognitive behavioral therapy for it. We did randomized controlled trials with several different medications. And had a really productive relationship, and I was able to get a faculty appointment, and here I am still here now, director of our center. And I would have to say, I'm happy to talk more about where things went from there, but I would have never thought I would have ended up, one, in a research position at a academic medical center, or two, publishing as much as I have over the years. I have about more than 150 publications, a couple books. Like that's not exactly what I thought I would be doing, when I sat in your shoes back in my undergrad years. And so I really just was open to new opportunities along the way. And yeah, and here I am somehow. Are there any questions coming in? I don't want to monopolize and just talk the whole time.
I think there's a few questions in the chat if you just want to go through them one by one.
Yeah, sure. Let's see. Why do I having trouble reading the first one because something popped up in front of it? Was undergraduate, what does that say? I have something.
Yeah, it says, was undergraduate or graduate school more enjoyable for you and why?
Oh, yeah. Well, they're just very different. Grad school's more like a job. So undergrad was enjoyable because, you're socializing quite a bit, and you're working really hard, right? And you're still trying to figure your life out. But I feel like there isn't quite as much responsibility per se in undergrad, even though you're stressed a lot of the time. Grad school, you go to your office every day, you're there for long hours, and again, not that you don't work long hours in undergrad, but it's just a different feel. Like you definitely have more mature responsibilities, and you have to be more focused on your own deadlines and getting your own work done to progress through your graduate career and really, pick your thesis and dissertation topics. So I feel like it's just, you feel a little more grown up for sure when you're in grad school, and it is more like a job, I would say, than undergrad. And there's still a lot of socializing, but it's definitely more like a job, I would say. So I enjoy both, but I think the setting, matters as well. I was at Miami University, which is beautiful. It's in the, southwest corner of Ohio, and was, but it's still a small town in Ohio, and I was used to the East Coast. And I think when you're not in the undergrad setting, I think it would have been nicer to be in a bigger metropolitan area, perhaps. So that was just my own experience. But that, I think, is something to think about when you're looking at grad schools. Like you don't have quite the built-in social capacity that you do in undergrad, and it would have been nicer to be in a place that had a little bit more going on. So on the social side, I will say that. All right. You alluded to the importance of ethics in the field of clinical psychology. How did your experiences as an undergrad or in grad school help you in creating your own work on your thesis on eating disorders in college? Yeah, I think one of the big issues, it was just a simple survey that we did longitudinally, that we launched longitudinally. But even with the surveys that we rolled out, I had to talk with several administrative boards because we were targeting, just in general, these freshmen that were just coming into college. So some of the ethical considerations that we had just for a survey study was, one of the surveys I gave was a screener for mood disorders or depression, and there was an item on there that assessed suicidality. And so, I really had to present a plan of how quickly was I going to be checking the surveys, what would happen if somebody did endorse suicidal ideation, how would we handle that? Would it be reported? Would it not? Because it's research, right? So it's supposed to be confidential. So that was, just one thing to think about. But then just on the topic of being confidential, you know, you're in an office with other grad students, you have surveys lying around, like you really do have to be mindful where you keep your materials that come in. If people did have their names or identifying information on there, that's another important thing to remember in clinical research, is just how you handle sensitive information with health identifiers. And that's no joke. You know, I think over the years, you've probably heard of people losing memory sticks or laptops getting stolen, you know, with sensitive information on there. And, you know, I think when you do clinical research, you really do have to respect your participants and their privacy. And the whole premise of clinical research is built on us not taking unnecessary risks with our participants. And that certainly includes being careful with their data. So even in a survey study like that, you definitely want to be mindful that you're storing your data properly, and that you're not keeping information longer than you need to, or, you know, just leaving it lying around. So I would say in surveys, studies, like those are kind of the basics. You know, now I do much more advanced clinical research, and we are always weighing kind of the pros and cons. So for example, one of the studies I'm doing now is looking at the timing, the impact of the timing of eating on weight and metabolism. And it's, you know, pretty complex protocol. We bring in people for 4 different overnight assessment visits at the Clinical Translational Research Center at HUP. And basically we assign them to 2 different eating conditions. So in the first eating condition, they eat on a daytime schedule. So they eat all of their food between 8 a.m. and 7 p.m. And on the second eating condition, they eat all of their food between noon and 11 p.m. So it's basically shifted back by 4 hours. And they eat on both conditions for 8 weeks at a time, with a 2-week washout in between. And some start with the daytime condition, some start with the delayed condition, then they have their washout and they'll switch and they'll eat on the other condition. But before and after those 8 weeks, they're at the hospital overnight. We have somebody in there right now, as a matter of fact, and they get their blood drawn every 4 hours. We take an adipose tissue sample, a sample of fat from the buttocks, to get a sense of how circadian changes in eating might impact at the cellular level of fat tissue. We're doing indirect calorimetry to measure resting energy expenditure and respiratory quotient, doing DEXA, and we do a frequently sampled intravenous glucose tolerance test to look at glucose metabolism and how that might change based on the timing of eating. So there's a lot of poking and prodding that we do, and we had to weigh very carefully the necessity, right, of each of those tests that we were doing to weigh the risks and the benefits. You know, the benefit of finding out whether or not, you know, any of these particular measures really are at the heart of what benefits we may see from eating earlier in the day versus later. But the risks are, you know, sometimes people can get hypoglycemic when we're doing the glucose tolerance testing. It can be hard to keep a line flowing for the blood draws, and that can be really uncomfortable, and people can develop phlebitis from changing the lines. You know, there are real risks involved with poking and prodding people like that. Even if the question is super interesting, like, we need to make sure that the risks are not outweighing the benefits of the science. And that's always a part of planning a study and then getting it passed through the institutional review board. And so every year we have to, you know, submit a continuing review to the review board. And every 6 months, we submit a report to our safety officer, and we have to list out any adverse events that have happened, you know, how many people have dropped out, really just to continue to monitor, is the study being run safely, and do the benefits still outweigh the risks for the participant. So I feel like, you know, depending on what type of research you're doing, the ethical considerations can really vary. Yeah. All right. What does a typical day look like for you? Well, The reason I love my job is because I do a ton of different things and my days always look really different. And I think this is why I'm really glad, me in particular, why I didn't just go into private practice, because what I do now is a variety of things. I do clinical work and I do research and I do a lot of supervising and mentoring. So in my role, I so let's just start with the clinical. So I do bariatric surgery, psychological evaluations. Our center does those evaluations for all three of the Penn medicine hospitals in the city. So Hop Presbyterian and Penn Presbyterian and Pennsylvania Hospital. So right now I do about a day of those, and then I supervise our postdoctoral fellow and our psychology intern on the ones that they do. And those are super interesting. I love that work. Really just making sure people are prepared and they know what they're getting into for bariatric surgery. It's a great population, just all walks of life, all ages, all different backgrounds. You never know who you're gonna talk to, and they could look super complicated on paper, have bipolar disorder, have recovered from a substance use disorder, and they could be super ready for surgery. And then somebody else who looks like they've never had any issues, can't get their stuff together and haven't started working on any changes, right? So it's just super interesting each day, doing those. So that's one aspect of what I do. And I do also provide psychotherapy for patients seeking help with either weight management or disordered eating. So I see a handful of patients, 5 to 8 patients a week, for a variety of weight and eating disorder issues. So in a given day, I could have a couple patients. I could then also be working on my research studies, so a meeting or watching part of a participant's visit to make sure it's going smoothly, meeting with my coordinators. And then I also supervise, as I said, some of the fellows and postdocs, and I give talks or lectures for classes here and there as well. So I feel like I do go from thing to thing each day, and I always have to fit in writing around everything else, writing grants and writing papers. So oftentimes it's like, oh, I still have 3 more things I wanted to check off on my to-do list, but I have to get home because I do have a family and kids, and I enjoy spending time with them as well. So my day is pretty varied. And when I was doing clinical work and you're seeing like 8 patients a day, I just found that to be really intense, and it can be really draining. And, I admire people who can do that all day long, but I felt like I really needed, more of a variety in my day. And that's why I love being able to do research and clinical work and what I do. Great. So the next one is, was there a specific spark that got you motivated to pursue research regarding eating? I think, as I mentioned, it really was in regards to just my personal experiences in athletics. And I thankfully never had an eating disorder, but I saw it all around me, and it just fascinated me. Again, like what would trigger one person if we're all on the same team, right? Was it their body shape and size, the way people interacted with them, to go down that path? And it just made me think about like the genetics that must be there, the way people intercept messages around them and be able to make sense out of those, whether or not they had supportive friends and family who either did emphasize or did not emphasize weight and shape. So, that I think was the impetus. And then I just had kind of an open mind, or I would have never come to Penn to study night eating syndrome because that was nothing I had ever heard of before. But I think then once you have that spark, I think just like in finance, right, you have to have a diverse portfolio to make things work. I have found in research, like if I had just stayed with night eating syndrome throughout the rest of my career, I would have never made it past assistant professor. I would have never been able to fund myself, because it's not like the National Institutes of Health thought, yes, let's fund everything on night eating syndrome that we can. So I ended up, becoming interested in a lot of obesity related work. I've done a lot of work in weight management during pregnancy and weight management following cancer diagnoses, because that can be a risk factor for recurrence. I've done a lot of work with bariatric surgery. So I became kind of a jack of all trades within the weight and eating field. And in academia, that really serves you well because you really do need to be able to be engaged with a variety of topics to keep yourself funded in a soft money environment like we have here at Penn. So I try to keep my eye and do things that I'm super passionate about myself still, but I hardly ever turn down an opportunity to work with colleagues when I'm invited on a project, even if it wasn't my first love, because these are things you just have to do. And it's going to be intellectually engaging no matter what, right? But you just have to keep that open mind, even if it wasn't the thing that, got you passionate about the field in the beginning. I try to always just find something interesting in anything that I do, just, to keep engaged and keep going. All right. How does cognitive behavioral therapy work when it comes to treating eating disorders? So CBT was developed by Dr. Beck, who you may or may not have heard. He just died actually 2 weeks ago. Such a sweet man. He was at Penn for most of his career. I had the great opportunity to meet him and sit in on seminars with him when he was actively here at Penn. And it's a really interesting therapy in that it's really present focused. And that's what I love about it. I feel like it's really focused on problem solving. And you think about an antecedent, like a trigger for an event, and then you think about how we respond to that. So then we would have emotions in relation to that event, and we would have thoughts, automatic thoughts, we call them, that just pop into your head right around what's going on. And then you end up acting on those things in one way or another, and that leads to some kind of consequence. So let's just say with bulimia nervosa, right? So maybe I have a test coming up, an exam, and I know I have to start studying. I'm kind of tired and I'm a little overwhelmed, and it's hard to get myself to sit down and start studying. So I, was walking home from studying, and I passed by Wawa, and I went in and I ended up, buying a bunch of different foods, came home, ate them all. Then I'm feeling really uncomfortable. So then, unfortunately, then I purge, and then I'm just feeling awful, right? Because you're fatigued, you're probably hurting in some way, maybe your throat or your stomach's upset, like you just don't feel good, and you're exhausted. And who's in the shape to study at that point, right? So then the consequence is you don't get any good studying done, and you probably don't do so well on your test. You feel guilty about that. You say, I'm never going to do this again. You start restricting the next day because you feel kind of gross from all the overeating. And then you can't keep the restricting going, and the cycle repeats itself. And so as a cognitive behavioral therapist, what I would do is identify that pattern. Okay, well, what could we have done from the beginning? How could we have gotten you set up better for success from the beginning and had a better plan for studying? Maybe with, somebody that is in your class, make a study date so that you're not alone if you know that it might be a time that triggers you. If that doesn't work, what's the next part we could intervene in? Okay, before you walked into that Wawa, could you have called somebody, or could you have distracted yourself or walked home a different way if you knew that that was going to be really problematic for you to just keep walking past that Wawa? So we basically just try to intercept what are the thoughts, what are the emotions, and how can we come up with alternative responses in that moment to really try to give people better coping mechanisms other than using food in that moment, or the absence of food if people are overly restricting. It kind of depends obviously on the situation, but I really just try to intervene in the everyday workings and doesn't necessarily focus on what happened in childhood that made you do this. It's not that we don't talk about the past, but a lot of the therapy is really spent on how can we get you to respond differently when you have these thoughts coming at you fast and furious that you're no good, or that, just a lot of negative stuff usually is obviously what I hear, but how can we get you to respond differently to those thoughts in a way that's a positive coping mechanism instead of something that's just going to perpetuate that cycle? Hopefully that answered the question. Let's see. Okay. What was, okay, typical day? Oh, when I was a postdoc, what was a typical day like? Well, then you are working for, somebody else's research study. So as a post, a lot of times, sometimes, and also you might be running your own little pilot studies to gather data so you could write your own grants. So I was kind of a project manager. I ran a study on night eating, and it had an inpatient and an outpatient component. So I was basically tasked with just overseeing the trial and making sure everything ran very smoothly, right? The recruitment process, the screening process, I was in charge of doing a lot of the initial psychological assessments, and then making sure that the inpatient assessments that we had with overnight stays, we had sleep studies done and serial blood draws done, just making sure that everything was set up for those visits, and everything was scheduled appropriately. And then as a clinical psychologist, when you're on your postdoc, it's also a time to get your clinical hours in. You have to have so many hours of clinical contact to be able to sit for the licensure exam and then become licensed as a clinical psychologist. And so I was doing clinical research, so those hours counted, but I also needed to be seeing some patients. So I did also see several patients. I sat in with Rob DeRubis, who is still here, and some of you may know in the Department of Psychology, in one of his practica, and saw patients in his mood disorder clinic while I was here as a postdoc as well. So it's a time to learn how to do research, and depending on which way you're going, if it's all research, then that's probably what you're focused on. But if you're in a clinical field, it would also be a time to get some more supervised clinical hours to meet your requirement for whatever state you're going to be practicing in before you can sit for the national licensing exam. And then each state has its own licensing exam, and you have to pass both to get licensed in whatever state you will be practicing in. Great. Have your research interests evolved over the years? And if they have, how have they evolved? I know you're still involved with weight eating, but compared to graduate dissertation, you later focus on different aspects of eating psychology. Yes, absolutely. And I think this is what I talked about with like really branching out. So I was really focused on kind of what we think of as the traditional eating disorders early on, anorexia nervosa, bulimia nervosa. But coming to Penn, our department, our Center for Weight and Eating Disorders, is really more focused on obesity work and disordered eating that has to do with people with higher weights and people who live in larger bodies. And so I really did shift that focus, and really wasn't something I thought I'd be doing, really trying to figure out effective ways to deliver behavioral weight management, even bariatric surgery, right? That wasn't something I thought of early on that I would really enjoy doing and working with that population. And I do both clinical work and research with folks with bariatric surgery now, and I really love it. And then even like with cancer, and I work a lot with reproductive endocrinologists, doing research with women who have PCOS, because they often struggle with their weight. They have insulin resistance a lot of the time, and they have trouble losing weight more than the general population. They also have more disordered eating. So I've developed a nice collaborative relationship with some of the reproductive endocrinologists, and we've done quite a few studies looking at behavioral weight management and psychotherapy delivered to that population over the years. We have a grant in right now that's being reviewed on a fiber supplement intervention to see if that might help with symptoms of PCOS too. So those are things I would have never thought I would have become interested in, but certainly have really developed those interests over the years. And even like I said, going from a survey study back in my graduate school years to now the complicated protocols that I do now, in the inpatient unit at the hospital, looking for mechanisms of change of, why an early eating schedule, might be more beneficial than a delayed eating schedule. I had to do a ton of learning, right, that I did not have in my graduate school. Like my graduate school was really focused on psychology and theory. And then bam, when I came as a postdoc, I had to learn a lot about biology biology, that I just didn't have that background about what hormones are really integral in appetite and satiety, and how they might impact our different ways of eating. So that was something I actually learned as I went, in my career over time. And that's something that, like, that's why you go to conferences and you go to seminars and you never stop learning, because that's just not the background I had when I thought I was going to be hanging out a shingle and doing therapy for the rest of my life. So I think that's part of being an academic, is just making sure you keep that open mind and continue to, attend seminars and keep kind of that beginner's mind, so that there's always something new to learn.
Also, I'm so sorry to